All right, I think we'll go ahead and get started now. Good afternoon, everyone, and welcome to Part 1 of the two-part CEHN webinar series, Protecting Children from Lead Exposures Through Water, Introducing the Lead Service Line Replacement Collaborative. Before we get started, I'd like to review a few housekeeping items. We will keep all lines muted during the presentations to avoid background noise. If you have any questions during the webinar, you can submit them at any time to the chat box in the lower left corner. We will answer as many questions as possible during the question and answer session at the end of the webinar. Those questions that are not answered within the webinar time allotted will be addressed and answers will be sent to all attendees in a few days. Finally, you will receive a short survey after the webinar. Please fill it out to help us improve for Part 2 of the series. I'd like now to introduce Ensei Abbott Witherspoon. Ms. Witherspoon serves as the Executive Director for Children's Environmental Health Network, where her responsibilities include leading policy, education, and training, and science-related programs. She has served as a leader and key spokesperson for children's vulnerabilities and the need for their protection for over 16 years. Currently, Ms. Witherspoon serves on the NIH Council of Councils and the Science Board for Centers for Disease Control and Prevention. In addition to previous leadership roles, she is also a board member of the Pesticide Action Network of North America and serves on Maryland Children's Environmental Health Advisory Council. Ensei will be our moderator for the webinar and our fourth and final speaker. Welcome, Ensei.
Thank you so much. Good morning and good afternoon to all of you, and thank you for your time in joining us today. I will introduce our fantastic speakers and just let you all know as far as format, we will again have questions at the end of all the presentations, and I do look forward to a good engaging discussion. Our first speaker will be Dr. David Bellinger, a pediatric neuropsychologist and environmental epidemiologist, a professor of neurology and psychiatry at Harvard Medical School, the Boston Children's Hospital, and a professor in the Department of Environmental Health at the Harvard CEHN School of Public Health. His research focuses primarily on children's chemical exposures and has included studies on lead, methylmercury, elemental mercury, arsenic, manganese, fluoride, organophosphate, pesticides, PCBs, and general aesthetics. Excuse me. He has published more than 400 papers and has been invited to lecture in 24 countries. He's the editor-in-chief of Toxics and an associate editor in Children's Health of Environmental Health. He is the president of the International Society for Children's Health and the Environment, chairperson of the World Health Organization Committee on Guidelines for the Diagnosis and Treatment of Lead Poisoning, and a member of the WHO Expert Advisory Panel on Food Safety. Dr. Bellinger will be speaking on the effects of lead on children's health. Our second speaker will be Dr. Adam Spanier. He is an associate professor of pediatrics at the University of Maryland. Dr. Spanier has focused on pediatric environmental health research and clinical care for his entire medical career. His research centers mostly on pediatric asthma in the environment, such as tobacco smoke, particulates, and allergens, just to name a few, but has also included lead poisoning and injury prevention. From 2007 to 2009, he was the medical director of the Pediatric Lead Clinic in Cincinnati, leading the clinic's expansion into the Pediatric Environmental Health Specialty Unit, affiliated Pediatric Environmental Health Clinic. He is the editor of the Environmental Health column of Public Health Reports, the official journal of the U.S. Public Health Service. He is also a member of the EPA's Child Health Protection Advisory Committee and a member of the Executive Committee of the American Academy of Pediatrics Council on Environmental Health. And he is the division head of general pediatrics and the medical director of pediatrics at Midtown, the University of Maryland Department of Pediatrics Outpatient General Pediatrics Clinic. And Adam is also a board member for the Children's Environmental Health Network, so we're also glad to have Adam. Mr. Tom Neltner is Environmental Defense Fund's Chemicals Policy Director. He leads efforts to remove or minimize hazardous chemicals from products and the marketplace through cost-cutting policy initiatives. He's a chemical engineer and attorney with experience in chemical safety issues in the workplace, the environment, the home, consumer products, or food. Tom has worked on lead poisoning prevention at the federal, state, and local levels for over 20 years. He more recently has played a leading role in EPA-convened multi-stakeholder work groups that made recommendations to the agency to upgrade its lead in drinking water regulations. He has worked in chemical, food additive, pesticide, and pharmaceutical manufacturing, as well as state, government, and public interest advocacy, with some work as adjunct professor at Indiana University through many of those years. He supports Environmental Defense Fund's work on chemical safety, especially lead, formaldehyde, and hazardous materials management. Thank you to all of our speakers, and Dr. Bellinger, the floor is yours.
Thank you very much, Ensei, and good afternoon, everyone. My role is to provide a bit of the context for why the lead service line replacement collaborative work is so important. So I'm going to, in a very brief period of time, talk about the effects of lead primarily on children's neurodevelopment. The literature on lead, as many of you know, is broader and deeper than for any other chemical, so I'll only be able to hit some of the high points in my comments. Could I have the next slide, please? Now, the reason that neurodevelopment is the primary target of lead is that neurodevelopment is so complicated and extends over quite a long period of time, from the prenatal period actually through the lifespan, with most of the activities occurring in the first 2 postnatal decades. And this slide across the top shows some of the major processes involved. So cell proliferation is the production of new brain cells. These cells are born in neuron nurseries and have to migrate to the right place in the brain. Subplate neurons are really critical in organization of the development of the cerebral cortex, and you don't want anything to interfere with their process of organizing and regulating cortical development. And then later on, neurons start to connect up with one another to form neural circuits. And you can see that the horizontal line is birth, that many of these processes they start prior to birth but extend quite a long time after birth. And you can see that synapse formation goes into the second decade of postnatal life. And then over on the right is process of myelination. This is the coating of neuron axons with a fatty sheath that increases the speed of processing, and so we don't want anything to interfere with myelination. And myelination also in certain areas of the brain extends well into postnatal life. So any chemical that affects any of these processes can be potentially detrimental. And I like to think of brain development as it's an exquisite spatial and temporal choreography. Things have to happen at the right time and in the right place to end up with a brain that is as it was intended. Could I have the next slide, please? Now, lead, unfortunately, is a very bad actor. Almost any process in the brain that anyone has looked at is disturbed by lead in some way at some dose. And I won't go through this long list, but I will point out just a few. Lead poisons the mitochondria, which are little organelles in most of our cells that produce energy. And so, and the brain in particular is the most energy dependent or most energy thirsty organ in the body. So we don't want anything that interferes with the amount of energy that's reaching the brain. Lead also impairs the synthesis of heme, which is part of hemoglobin. So this is the system that carries oxygen around to different cells of the body. And the brain also is very oxygen dependent. And so anything that interferes with heme synthesis, reducing the amount of hemoglobin, is something to be concerned about. And then lead also affects the neurotransmitters that are the way that different cells in the brain communicate with one another, how they pass information from one to the next. And so any interference with the fidelity of that process is something of concern, because It basically introduces noise into the functioning of the brain, scrambling the signals, and so leading to a result that is not what we would like to see. Next slide, please. Now, in humans, we have a hard time looking at drilling down to some of these granular processes, but we can do imaging of the brain and see if exposure to lead is causing any changes in brain structure or function. This is a slide from a very important study, the Cincinnati prospective lead study, where children were followed from the second trimester of gestation all the way out to as old as 24 years of age. And when these participants were adults, they did what's called volumetric imaging. And so they were able to measure the size of different portions of the brain. And what they were interested in is whether or not the brains of children who had been exposed to more lead in early childhood were different than the brains of children who were exposed to less. So if you look at the top of this slide, this is a sideways view of the brain, sort of cut down the middle and opened out. And the areas of red and yellow are areas in which there was volume loss. The size of these regions is actually smaller in a dose-dependent way in relation to childhood lead exposure. And this primary area of volume loss is in the frontal cortex on both sides of the brain, the left and the right hemisphere. And this area of the brain is very important in terms of what's called executive functioning. That is the ability to resist impulse, to delay gratification, to plan for the future, to anticipate consequences. It's really a very, very, very important function in terms of predicting life success. So this is very worrisome that lead exposure 2 decades before the volumetric MRI studies were done is revealing persistent brain abnormalities in a dose-related way. Could I have the next slide, please? This is a slide that summarizes some of the key findings of the most recent comprehensive review of the lead literature done by the National Toxicology Program of NIEHS. And they found, using very rigorous criteria, that the evidence was sufficient that even below 5 micrograms per deciliter, children experience decreased IQ, difficulties with academic achievement, and difficulty with other cognitive functions such as executive functions, and an increase in attention-related behavior problems. And at levels below 10 micrograms per deciliter, there's evidence that children have delayed, with higher exposure to lead, experience delayed puberty, reduced postnatal growth, and decreased hearing. For other endpoints, the evidence was more limited and in some cases entirely inadequate to draw any conclusion. But these areas where the evidence is sufficient are of considerable concern in terms of children's quality of life and their ability to fulfill their potential. Next slide, please. This is quite an important slide that is the result of pooling the data from 7 different prospective lead studies done around the world. The total sample size was over 1,300 children. And the goal of combining the data was to get a more precise estimate of what the relationship between increasing lead and IQ is below 10 micrograms per deciliter. At the time the study was done, 10 was the CDC the action level. And what this set of analyses showed was that 10 was not providing an adequate margin of safety. There's an inverse relationship below 10 micrograms per deciliter, extending all the way down to 1 to 2 micrograms per deciliter, such that as children's blood lead increased, their IQ scores went down. And in fact, what was somewhat surprising was that the rate of decline of IQ was greater per microgram per deciliter increase in blood lead below 10 than it was above 10, which meant that we couldn't remain with 10 as the action level. And this was a key piece of evidence in motivating the CDC to get rid of the action level of 10 and substitute a reference value of 5 back in 2012. Next slide. Now, we've known for close to 40 years now, starting with my colleague Herb Needleman's study here in the Boston area, that children who have more lead in their body, in this case more lead in their baby teeth that he collected, show much worse classroom behavior as rated by their teachers. So children were classified into 6 groups based on the amount of lead in the dentine layer of their shed baby teeth. And teachers responded yes or no to questions such as, is this child distractible? Is the child not persistent? Is the child dependent, not organized, hyperactive, impulsive, frustrated, a daydreamer, not able to follow directions, and just not doing as well as peers? And you can see for most of these dimensions, there was a steady stepwise increase in the percentage of negative responses as children's tooth lead level increased. So this really, I think, was a very important study in stimulating interest in subclinical lead exposure, children who didn't seem to be suffering clinical signs of toxicity, but may nevertheless be impaired in terms of their ability to manage important settings such as school. Next slide. Following up on that kind of finding from Herb Needleman's study, Joe Braun did a study using the NHANES data where he was interested in whether or not children with higher blood lead levels were identified as having ADHD. And this was based on asking the parents, has a medical professional told you your child has ADHD? And is your child taking a medication that we know is typically used for children with ADHD? And what Joe found was that when blood lead exceeded 2 micrograms per deciliter, children were at 4-fold increased risk of meeting criteria for ADHD compared to children who had a blood lead less than 0.8 micrograms per deciliter. And there didn't seem to be any threshold that the children with intermediate blood leads had intermediate risk of ADHD. Next slide, please. Well, not surprisingly, if we know that lead decreases IQ, makes children less attentive, maybe more restless, they probably aren't going to do as well in school. And that certainly is seemed to have been borne out by numerous studies. This is just one study from North Carolina of more than 8,000 children looking at the percentage of children by blood lead level who failed an end of 4th grade reading achievement test. If you look at the black bars, that's all children in the sample. You can see that children who had a blood lead of 10 or more had about a 30% failure rate on this test, whereas children with a blood lead of 1 had a failure rate less than 10%. And again, there was no clear threshold that with each microgram per deciliter increase in blood lead, there seemed to be an increase in the percentage of children failing. So this is, again, more evidence that 10 was not providing any substantial protection to children, and even 5 is not. And the CDC reference value is not a health-based value, I should add. Next slide. This slide shows the percentage of children in different categories based on their performance. The red curve is children who are considered to be advanced and intellectually gifted. And you can see what happens as blood lead goes from 1 to 10. There's a drop from about 18% of children to about 5% of children being considered gifted. And the percentage of children considered learning and behavioral exceptional, which is the kind of light green, goes from 4% among children with a blood lead of 1 up to almost 12%, a 3-fold increase for children who have a blood lead above 10. And the other curve, the purple, is children who are designated exceptional for other reasons. They have physical or sensory problems, autism spectrum disorder. We don't think that those are related to lead. There's not much evidence of it, and so we don't see a whole lot of change as we go from 1 to 10. Next slide. There's even now some evidence from numerous studies that children with higher lead exposure are at increased risk of committing violent acts. This is a slide from the Cincinnati study that generated the MRI studies that I showed you previously. This shows that what a child's blood lead level was in early childhood is significantly related to the likelihood that they'll be arrested as an adult. This is a little surprising, but I think the next slide provides a sense in which this starts to make a little bit more sense. I think we've tended to focus on IQ as the be-all and end-all, but it's really just the tip of the iceberg and the start of the story. So I think there is such thing as developmental cascades, that a child who is exposed to lead early on, they are at risk of having a reduced IQ. Their executive functioning that I talked about is reduced. They have trouble resisting impulses, and they can't delay gratification. Now, some of those children are going to go on to do more poorly in school. Some may meet criteria for ADHD or conduct disorder. We know that there's an association between lead and substance abuse and increased injury risk. And these are children who may reach a point where they don't find school very satisfying. They look for satisfaction elsewhere. They may make poor life decisions, put themselves in a situation where criminal activities is a possibility, and so end up engaging in criminal activity. Now, certainly not all lead-exposed children are going to follow all of these points of progression and transition points, and I think that each of these transition points is an opportunity for intervention, and I don't think we've spent enough time trying to determine how best to help these children to mitigate the adverse effects of lead. I just want to finish with the last couple of slides, which I think puts this in a societal perspective. We always are concerned about the individual child, and we certainly should be, but I think we need to also be thinking about what we're doing to the entire population of children. And I've been presenting this kind of work for many, many years, and I always get a question, well, the effect of lead on a child is to reduce the IQ by 3-4 points. That's not clinically significant. We shouldn't be concerned about that. We should be concerned about other pediatric events and medical conditions that are more important. So I've been thinking about ways to express the risk, to communicate the risk that lead is posing to our society with these couple of slides. What I have done is to calculate the total IQ loss in the population of children 0 to 5 years of age that is attributable to lead. So I matched up the blood lead distribution from N. Haynes with the dose response information from that pooled analysis that I mentioned involving about 1,300 children. And I went through a series of very simple calculations. I knew how many U.S. children are in different points of the blood lead distribution. So 50% of the children have a blood lead between 1 and 1.4 micrograms per deciliter. There are about 25.5 million children 0 to 5 years of age, so 50% of those is 12,750,000. 0.71 is the midpoint of the blood lead range, and 0.51 is the slope. That's the IQ loss per microgram per deciliter increase from the pooled analysis. So for children in different blood lead categories, I was able to calculate the total number of IQ points lost. And the total is almost 22 million IQ points. And could you go to the next slide, please? Strikingly, about half of that loss is among children who have a blood lead of 2 or less. Now, the impact per child is more modest than it is for children who have a blood lead, say, above 7.5, but so many of the children are in this blood lead range, and because lead has no threshold for adverse effect, every child is contributing something to this total IQ loss. So lead is really a paradigmatic example of a low morbidity but high prevalence condition, and the aggregate effect projected over the entire society is really substantial. And this calculation suggests that we need to be focusing not just on the high-risk children that have the highest blood leads, but on lowering the population exposure throughout the range. And as part of this set of calculations, I looked at the IQ loss that can be attributed to a variety of other pediatric conditions to try to come up with an answer to that question that I frequently get. So go to the last slide, please. So I went to the literature and found out the IQ loss associated with different pediatric conditions and the prevalence or incidence of different conditions. And this is what I found, the total number of IQ points lost for these different conditions. You can see lead and organophosphate pesticides are right up there at the top, greater than brain tumors, congenital heart disease, traumatic brain injury, iron deficiency. So again, this I think tells us that we need to take a societal approach to reducing the morbidity associated with lead and other chemicals. And I think I will stop there for now. Thank you very much.
Thank you so much, Dr. Bellinger. As a reminder, all participants can start typing in some questions that you may have, and that we will help to manage those at the end of all the presentations. Thank you very much. Dr. Spanier.
Thank you. So my role in this conversation is to give the pediatrician's perspective, and I think it's interesting to come right after Dr. Bellinger's presentation, where he just talked about it being a societal solution. As an individual provider, I can tell you that there is the larger societal issue, but it also comes down to having to have these conversations with parents and treating the individuals, and it gets a lot more complicated when it's on an individual level. So what I want to do briefly is talk about how pediatricians are trained regarding lead poisoning, a little bit about our guidelines, and in between I will talk a little bit about some of my personal experiences. As Ensei mentioned, I ran the pediatric lead clinic in Cincinnati, and I also on a regular basis get to see children for checkups and discuss lead and get to learn about all the different requirements by state. So if we can go to the next slide. The WHO has environmental health training package, and I pulled out a little case study from there, partially to contrast it with what we actually get to see more of in clinic. But this study shows a 5-year-old boy with hyperactivity and abdominal colic. The history is the mom works in an automobile repair shop where the child plays. On exam, this child's in the 10th percentile for height and weight, has a short attention span, is restless, has delayed speech and development, and poor social skills. Next slide. In this case, to be honest, I think most children who have lead poisoning are relatively asymptomatic. The abdominal colic in an astute pediatrician would set off an idea of doing more of an evaluation with laboratory testing. So in this case, the child had microcytic anemia, a blood level of 30, and a hemoglobin of 10.7 with MCV of 72, and normal serum calcium. To be honest, so this is WHO, so in America, I would imagine these tests are more than most people would order. Flat abdominal film was done with no radio opacities. You might see that with evaluation of abdominal colic. It's actually not a bad idea to do that when you're considering lead poisoning, to look for some radio-opaque lead paint chips. The blood lead level, though, in the mom here happens to be 40 micrograms per deciliter. And I think that this is a really good example. It's something I saw when I was in Cincinnati once or twice, where the child's exposure was actually more related to the parental occupation. So sometimes testing the parent leads you to the source of exposure. In the next slide, we'll talk a little bit about the management. The most important part always with lead poisoning is to find the source and abate it. So in this case, you would talk about cleaning, proper hygiene for the mom regarding, don't let your child play at work, and make sure you're changing your work uniform before you come home, washing hands. We have a tendency to treat the anemia because the way lead is absorbed is very similar to the way iron is absorbed. So the hope is that there'd be some competitive inhibition and absorption if you're making sure that the anemia is being treated. The medical requirements for chelation therapy are fairly strict. Most people wouldn't chelate a child with a blood lead level under 45. So in follow-up, this child's case demonstrates a decrease in lead over time, which is very common with what we find in clinical practice. A child with an acute lead exposure usually will have a pretty quick decline in lead if their exposure source is removed, but a child who's had a more chronic exposure, it can take a much longer time for their lead level to decrease, largely due to the fact that we store lead in bone when we're chronically exposed, and it just takes such a long time for bone to turn over. So this child apparently had a very successful case, and they were asymptomatic 4 months later. The other example is in the next slide is I borrowed from the PrEP program is a pediatric board exam test PrEP is a plan that most people go through when they're studying for their pediatric boards. So I went through the last decade and a half to find any questions I could find related to lead, to give an example of what we're being exposed to as trainees. So this question, a 1-year-old boy has a lead of 40. His parents have been renovating their 70-year-old home. There's no history of pica. Of the following, the most likely sources of this child's lead poisoning is. So, like all test questions, what's the most likely or most correct answer? Obviously they want you to think about the renovation and in an older home. So in this case, I didn't highlight it, but the answer would be household dust. So this is one level of what we're being exposed to as pediatricians. And then the next slide shows another question, which is a more recent question. You're seeing a 1-year-old patient in your clinic for a health supervision visit. You explain the recommended screening test for this visit to the medical student who's accompanying you. So we're teaching a medical student. And of the following, the most appropriate recommended screening test at this visit is. Well, I honestly don't like this answer because it really varies by state. A lot of the regulations regarding screening are done at the state level. So for a 1-year-old child in health supervision, no one's going to, I'll work backwards and say we don't do a ferritin or an iron. We all do a blood count to check for anemia, but that's not what they're trying to get at. They're actually trying to get at testing blood lead. And this is where it gets a little bit more complicated because the easiest way to check blood lead is by a finger stick, but that's not the gold standard to diagnose lead poisoning. You would want a venipuncture. I really should have gone back to find the exact answer that they recommend, but I think it's more of getting at what's given to us as recommendation for screening, which is what the next slide kind of addresses. For I don't know how long, for decades, the advice has been that we should screen children based on their risk level. So at one point it was universal blood testing to check for blood lead poisoning, but the the guidance has changed over time it's gone from a universal testing of blood to a targeted screening based on risk level. And the ages at which we're supposed to evaluate children for risk of lead exposure is between 9 and 12 months, you're supposed to do it at least once, then again at 2, and if a child is 3 to 6 and has not been evaluated before, they should be evaluated based, again, on their risk. So high risk, the definition, depending on where you look, is if you live in an area where 25% or more of the housing is built before 1960, or if 5% or more children have elevated lead, or if the information is not available, or if the child is Medicaid or Medicaid eligible, they're considered higher risk and they should get a blood test. Everybody else is in the low risk category and they should be given a questionnaire. The biggest issue that I personally have with this guidance is that there's not a standard questionnaire, and each state adapts things on their own. So the questionnaire for Kentucky is rather interesting. It talks about whether a family member works in road crews and things like that, and it gets at firearms a little bit more than the Maryland advised questionnaire. Although about 2 years ago, the health department in Maryland recommended that all children get a blood test rather than doing a risk-based. They want to go back to universal screening by blood test for everyone, at least for a period of a few years, to reassess risk. And then as a pediatrician, I can tell you, unless you're checking the health department's websites, you don't usually know the answer to the risks. So, I don't know how many of the housing units in our area were built before 1960 unless I do a little bit of research on my own. Some health departments are helpful. It will give you a list of zip codes that are considered high risk, and then you have to rely on asking the parent for their zip code and checking it against a table to see if it's one of the high-risk areas. And then the other problem is with questionnaires, one of the more common questions is, do you live in a home built before 1960? And there are a lot of families who don't remember how old their home is. So I don't know that it's been studied well, but I'd love to see how well validated any of these questionnaires are. But anyway, this is the main guidance. I'm going to get to a little more guidance in just a minute. The other thing I wanted to point out is in the next slide, the blood levels that are considered to be elevated. David talked about it a little bit, that the Centers for Disease Control and Prevention has changed. It used to be called the level of concern. Now it's the reference value. I think it's very dramatic difference from the 1960s when 60 was considered elevated to the more most recent changes brought it down to 5, and a pediatrician who's not paying attention to the literature and the news might not respond appropriately to a parent. If they do get a lead level of 15, they might say, oh, well, that's still normal if they're still living in the 1980s. Or if they aren't aware of the new changes, a lead level of 8, they might say, oh, that's normal. I've always taken the approach of saying anything over 0 is some level of exposure, although laboratory error is not perfect. So I always have a long conversation with parents when it's a non-zero result on a test. In the next slide, I just wanted to briefly get back to what I mentioned earlier, that most of the time what I'm seeing clinically is the traditional versus these non-traditional sources. So traditional exposure source, or the most common things we see with kids, are the lead-based paint. So in older homes, we see, particularly in areas of high friction like windows and doors, the paint will break down, become part of the dust in the interior, along the windowsills and on the floors, as well as in the soil around the home, and as well as in chips, paint chips. So deteriorating lead paint is a problem, and that's where we see most common exposure. So I put that font just a smidge higher. The other exposure sources that contribute are water, parents' employment, alternative medications, sometimes in ceramics, toys and consumer products. I used to get contacted by the media about all the time because we would find lead in a toy right around Christmas time, and everyone would worry, which is good. It's good to be vigilant about other exposure sources, but it also, I think, sometimes takes the attention away from the fact that we have a lot of older housing out there, and what we'll get to in a little bit is, we have a lot of older service lines too. So it's not just the toys, but they tend to get a lot of press certain times of the year. And then food. Food and some, I actually haven't seen food as the largest risk. I've seen in lead experience in lead clinic, the alternative medication. I had a patient who was taking Azarcon, which is a product given for abdominal pain in some Mexican areas that ironically elevated lead causes abdominal colic, so it's interesting that it was part of a treatment for abdominal pain. I've seen it also in some makeups from some other countries, but there's, again, the most common source is the lead-based paint. The next slide is a graphic I borrowed directly from the website from the American Academy of Pediatrics. It does also mention some of the common sources of exposure in the home. I like this figure. It's a pretty decent infographic that gets at the 37 million estimated housing units in the U.S. contain lead-based paint. It breaks down the percentile of homes by age. It also gives a really good guidance. None is the level of lead exposure considered safe for children. I think it's a great infographic. It's public access. Just go to the website for the AAP. But I sometimes feel like this isn't something that's emphasized as much as it should be with the trainees. The next few slides that I wanted to bring to everyone's attention are the American Academy of Pediatric Guidelines for lead. So for lead poisoning. So this is what, and I didn't intend for everybody to read, and I'm not going to read every single bit of this guideline. It's mostly here so that I can point out two things. AAP guidelines, every 3 to 5 years, we revisit whether or not we need to change the guidelines as new information comes about. I was part of the committee that helped put together the most recent guidelines, and 2016, it just came out not too long ago. There were two areas where advice was given. One was given for the government, and one was given for pediatricians, healthcare providers, and public health officials. And to be honest, this guideline changed the focus much more dramatically from what we do in practice, which is secondary prevention, to primary prevention. Let's try to prevent our children from getting exposed. So the focus was first on what the government should do, which is uncommon for our guidelines because our guidelines are usually focused on how does a pediatrician address a certain health issue. So the AAP and our committee took the steps to say that the government should expand resources for HUD and other state governments for lead work. The government should provide financial and non-financial resources and technical guidance, review protocols for identifying and mitigating lead hazards, and revise downward allowable levels that are, the criteria that the CDC and EPA and HUD set for what's considered safe in-house dust, soil, and paint. All of these should be more health-based rather than empirical. The federal government should resume and expand its role in public health leadership. They should revise current regulations for, I kind of mentioned before, laboratory error. So if our levels that we're looking at in kids, if our reference value is 5, but the error that's allowed in a lab test is plus or minus 4, a 1 might actually end up showing up as a 5. So we want much better lab results in order to address these tighter recommendations. The next slide, it continues. There's more. The government should continue to do things like the National Health and Nutrition Examination Survey, NHANES data, provide national trends in blood lead level, continue regularly surveying kids and adolescents about other related disorders like ADHD and conduct disorder. In consultation with pediatricians, develop policies and regulations requiring remediation of lead-contaminated housing, collect and analyze and publish lead test results so that the pediatricians have better guidance for which areas are higher risk. Provide resources for environmental evaluation. So this is a problem I used to see in Cincinnati all the time. The health department in Cincinnati had resources to go in and do a home inspection for children if their lead level was 10. At the time when I was in Cincinnati, that was the level of concern. The Kentucky Health Department, and Kentucky is just right across the river from Cincinnati, the Northern Kentucky Health Departments, most of them didn't have resources to go into a home until a child's blood level was 15 or 20. When your reference value goes from 10 to 5, there should be an appropriate reallocation of resources to permit or to help allow for inspections of these homes for the children with this lower levels of lead than were being evaluated before. And then the government should take steps to ensure that water fountains in schools do not exceed elevated lead levels. That sort of gets at the picture on the announcement for this particular webinar. So the next couple of slides get at the pediatrician's role. And again, when the lead author for this particular guideline is not a pediatrician, one of my particular problems or concerns when we were writing the guidelines is I didn't think that there was a lot that a pediatrician could actively do. A lot of what's here is us advocating. So advocacy is a little bit harder for somebody who's out in private practice or even in a busy academic practice. So work with public health officials to conduct surveys, recommend individual environmental assessments for older housing, promulgate enforcement of strict legal standards, and be familiar with collection and interpretation of reports of lead hazards. The average pediatrician might not be able to look at an environmental health assessment of the home and be able to provide advice to a family. And the next slide has a few more things that we as pediatricians are supposed to be doing. Be familiar with federal, state, local, and professional recommendations or requirements for screening. So that's an important one. So whenever so I've moved several times. When I moved from one state to the next, that's one of the things that I start to look at. What do they recommend regarding lead screening? And I mentioned that Maryland is a little different in that they want universal screening, at least right now, rather than risk-targeted screening. Verify that screening was performed elsewhere or and determine the result before testing in the office visit. Conduct targeted screening of children for elevated lead concentrations based on risk here. This is where it gets back at the guidance I mentioned earlier. Test children for elevated lead concentrations if they live in or visit an older home or one with a lead hazard. And work with federal, state, and local governments to ensure comprehensive environmental inspections. So honestly, I think that this was setting a really high bar for an average pediatrician, where most of my colleagues are having trouble just keeping track of all the changes in the literature. I think it makes it even harder for us to go out and advocate. And I'm not going to get too political and say that the current environment might make it even harder to push for some of these guidelines. But I think part of the reason for setting the guidelines the way they are was so that the AAP could make a strong statement about the importance of lead and evaluation for lead poisoning and in primary prevention, which I think would probably be the easiest and most appropriate solution. So I've told you a little bit about how we're trained as pediatricians. I showed you the most recent guidelines. They're a lot longer than this. Even though those are busy slides, it's even busier if you read the whole thing. And then my personal experience has been most commonly seeing elevated lead in children who are having exposures in their home-based environment. I work in Baltimore. Baltimore is an older city, so we have lots of older homes with lead-based paint, as well as we're potentially going to see some of the same issues with lead service lines if we see issues with changing of water sources, or even every once in a while we'll see problems when the water companies decide to change how they treat their water in their treatment systems. But I think Tom is going to get into that policy next. So that's all I have for the pediatrician perspective for now.
Thank you so much, Dr. Spanier. And Tom Meltner.
Thanks. And thanks, Adam and David. I always learn new things when you go through it. So I'm going to sort of make the drill down and focus on the water and then go relatively quickly so that we have time for questions after, and I'll turn it over to Nancy when I'm done. So let's move to the next slide if we could. So it's a report that came out last month from EPA. It's a draft report that's out for public comment and external peer review. Gave some context that may be useful. And they looked at where does it come from? Where does lead come from when we look at all the kids? So the percentile range is the percentile of kids exposure. So you just have to be careful. Blue is food and brown is water. I'm not sure why brown is water, and soil and dust are green. So the color coding is all off, but you can see for 0 to 6 months old, water is a significant source, and for some of those kids, paint is a bigger source. Food tends to be relatively small. But the surprise for me came from 1 to 2-year-olds, where food is the biggest source for probably 2/3 of the kids, and obviously paint becomes big. Water is a constant source, and as David pointed out, that's the kind of thing we want to keep reducing. I was just surprised by the food. If we can move to the next slide. When we look at water, it's important to realize that the water that's under the pipes under the street rarely has lead in it. Mostly it's coming from, it's added between the water main and the house, and that's through a lead service line or from the internal plumbing. So just if you look at that blue line that connects up the water main to the house, that's the service line. You'll see a property boundary, and whose responsibility of it is complicated. Sometimes it's the utilities for the whole thing. Sometimes it's utilities only for the stuff on public property. But that line is in about 6 million homes made of pure lead. And over time, it's developed a coating on it, but that lead gets into the water that we drink, especially when it's disturbed. One of the EPA expert once said, a large truck driving down the street can shake loose that particulate that ends up in what people drink. Inside, it's primarily the piping, the solder and the copper lines, or the brass fittings. It wasn't until 2014 that we really had low lead brass fittings. Before that, it could be as high as 8% lead and still be declared lead-free. So if we could go to the next slide, please. This is a picture of lead pipes on the two sides with a corroded steel pipe in between. One of the reasons I like lead is it doesn't corrode very easily, not like the steel pipe. So you can see the corrosion control is in it. And that corrosion control is added. It's typically a phosphates or a silicate that might be added at the treatment center to try to keep the lead in the pipe and not in the water, but it's not foolproof. And again, corrosion control is essential everywhere. The lead pipes are a big source. Next slide. So when we think about it, we got to remember, as David made crystal clear, there's no safe level of exposure to lead. So we want to get it as low as possible. Many of you may hear talk about the 15 parts per billion lead action level. And I really want to emphasize that number is all about corrosion control. It has nothing to do with health. And using that as a basis to decide what is acceptable or not doesn't make sense when you're dealing with an individual child. And I'll show you some new numbers later on for that EPA has just released. Last year, or actually late in 2015, an EPA advisory committee said to EPA that you need to set a health-based level, something related to health, obviously not zero, to help parents and health departments and local health and for health professionals provide some advice to the parents, to the community. And then in January of just last month, EPA released a draft report following up on that EPA advisory committee, and they provided health-based benchmarks. There is no safe level, but these are ones where it's something that you would take action on as a pediatrician or as a health department. Next slide, please. So EPA laid out 3 approaches, and I'm not going to go into the third approach because it's really dependent on the sources. But what they said is, for approach 1, let's just focus on a formula-fed infant. And what you have is, if you're aiming to try to keep that child's blood lead level from being elevated, which is currently at 5, and the plan is that it's going to be lowered to 3.5. That's not that it's safe, but it's a time where it's enough that it looks like CDC would recommend that you do a little more. So using those as some targets, they broke it up into pre-1950 home, where there's a lot more risk of hazards, 1950 to 1978, where there's less risk of dust and soil hazards, and then where there's no other exposure. And then they said, what is a 1% likelihood of having over 3.5 or over 5? So if you're looking at the most protective, if you're living in a child that's living in a pre-1950 home, if the water is more than 4.9 parts per billion, that child has a 1% chance of exceeding 3.5 micrograms per deciliter. So you can look at these numbers. What they've done, EPA has provided us with a menu of numbers ranging from 4.9 at the low end to, if you consider no other exposure, as much as 18 parts per billion, where you have a 5% chance. 1% chance is probably as low as they can get the probability to work. In approach number 2, they said, how much water would it take to raise the geometric mean in children up about a half microgram per deciliter? So you don't consider necessarily the other sources. And if you're trying to keep a less than a half microgram per deciliter in the blood, you're looking at around 3 parts per billion, or 1 microgram per deciliter would be 6.2. So those are different ways to look at it, but you can see that all but 2 of those numbers are less than 15. And that doesn't mean you can be less than 15, but you want to drive that number as low as possible. Corrosion control is one good way that all utilities can do it, but lead service line replacement is one that makes a big difference. Next slide, please. So when you look at toddlers, the number is up higher because toddlers drink less water, and they have other exposures that are more significant. But you'll see those ranges go from, if you're trying to look at the most protective, 8.1 part per billion to, and I just provided the 1% numbers, up to 38.5 parts per billion. So it gives you an idea of what kind of ranges we're talking about. Toddlers could handle more because they're not dependent like formula-fed infants on just one source. Next slide. Just to provide context, this is a draft report. It's out, there was a Federal Register notice on January 19th that described it. They're taking nominations. So if you know of anybody who's interested in this, David or Adam, nominations for the external review panel are due February 21st, and I even put a link there if you want to nominate yourself or somebody else. And then public comments are due on this on March 6th. So this is still out for comment, but it does represent EPA's best assessment of what kind of health-based benchmarks could be incorporated into a revision of a revised lead and copper rule for drinking water. Next slide. So how do you reduce it? Well, sampling doesn't actually reduce it, but sampling is critical, especially today. What we often think of as a first draw from the faucet after 6 hours of stagnation. And for a utility, that level is that if 90th percentile of those samples are above 15, they got to do some more. So right now, it's used as a trigger for upgrades or to assess compliance and performance. So sampling is critical in doing this, which means that we're going to only act when we have high levels of exposure, above 15, and we saw that those could be significant. Corrosion control is required for large utilities and for smaller ones if they exceed that lead action level. So there are utilities that are not necessarily doing corrosion control, so they could do more. But lead service line replacement is critical because it's a lead pipe and it can release particulate. The best estimate I've seen, it's about 70% of the lead in drinking water comes from that lead pipe. It's the primary source of particulate lead, and it is required as a last resort under the current rule. Next slide, please. I just want to point out that sometimes many communities, Cincinnati stopped using lead service lines in 1927. Boston did it in 1935, I think. But Chicago in particular they mandated lead pipes up until 1986 when Congress mandated it. But you'll notice that it's only up to 2-inch pipe. So we have seen, I know somebody who lives in Chicago with a 19-unit building that has 22-inch pipe, that's a lead pipe. So 2 inches is still pretty big, and it was required in Chicago. So many of that area, it's a big Midwest thing. Many communities, though, did get rid of it earlier. Next slide. So that's my review of where it's coming from and some of the latest numbers. The health-based benchmarks might be useful guidance for pediatricians. At Environmental Defense Fund, because we get so many questions, we're looking at suggesting some numbers there that doctors, pediatricians, health departments could use to guide investigations for water. But right now I'd like to turn it over to NSIC.
Thank you so much, Tom. Thank you all for hanging in there. I know it's a lot of content. As you see, we didn't want to make any assumptions. There's a lot of people that were registered for this webinar, and we wanted to make sure that at least the general foundation of why this is of concern and why this is unfortunately still of concern to children in 2017 was laid out pretty well, which again, I think our speakers did a great job at that. And I would also now like to transition us just briefly before we open up into the questions into the Lead Service Line Replacement Collaborative, which is a great framework and resource that can be available to all of you in helping to address these issues of lead contamination through drinking water. As a result of the very unfortunate legacy issues of lead that have been around for a long time, we still have yet to end this concern. And with this extra focused attention in the last few years, in particular with Flint, Michigan, and many other cities of concern, and that we unfortunately know are yet to come down the line when we talk about public health protections and our water systems, the Children's Environmental Health Network decided to join this important work of launching this Lead Service Line Replacement Collaborative. Next slide, please. So our collaborative is a diverse collaboration of national multidisciplinary groups: public health, water utility, environmental health, labor, consumers, housing, state and local governmental organizations. And in my personal opinion, it's one of the best collaborative efforts that I've seen in a while, as far as the focused determination of everyone at the table, people giving, in many cases, of their in-kind time and staff expertise to really make sure that we're meeting all goals. And our goal is to accelerate the voluntary lead service line replacement in communities across the United States. That is the end goal. No hidden agendas, just trying to expedite that process. Next slide, please. So as I think Tom talked about very well, he talked about how lead piping is organized, and how again, you've got pretty much private. Usually, the homeowner is responsible for the line past the property line into the area of the property, and then usually the public portion is going out to the street. But we do know that lead service lines are the largest potential source of lead in contact with drinking water. Next slide, please. So our collaborative guiding principles that we have all come around and agreed upon are: first, removal of lead service lines that provides an opportunity for communities to significantly reduce the risk of exposure to lead in drinking water, first and foremost. Also, that replacement initiatives must be designed to ensure residents are protected during and after removal, and that the work is done in a cost-effective manner. Now, we know that that is a big elephant in the room, and that is something that is also very important in the resources and research that we are trying to generate interest around for sure, but there are some communities across the country, states that are getting creative on how to afford this type of adjustment and replacement. Third, replacement initiatives should address barriers to participation so that consumers served by lead service lines can benefit equitably regardless of income, race, or ethnicity, and that we're a collaborative, community-based approach that can help provide the strong foundation needed for true success in providing a variety of different ways of technical assistance along the process. Next slide, please. Also, we're working on innovative models that are needed to help communities find the tools and strategies and resources needed to replace these lead service lines based on the latest science and current best practices. So we remain open to adjusting and tweaking as needed according to, again, best practices that emerge and certainly any new science. By providing models for replacement, it is possible to advance support all levels of government and in different types of communities. We also know that successful lead service line replacement initiatives will take careful planning and time. This is not going to happen overnight. The problem did not create itself overnight, but we know we are beyond the level of urgency to get about the business of really getting serious about strategy here. This effort is focused on mechanisms to support local action and, to be very clear, not on EPA's efforts to revise the lead and copper rule. Next slide, please. So what are we doing? We are preparing information and tools and models and trying to look at demonstration opportunities across the country for communities and states that are utilizing aspects of the tools and resources and moving towards progressive steps towards replacing these lead service lines in their community in a very proactive basis, and providing information on achievable, cost-effective, safe lead service line replacement options. We're capturing and sharing these lessons learned in communities and making it transparent and available to the general public, and providing technical assistance and facilitation informing initiatives. Next slide, please. So where would you find all of this? So we did launch last month the Lead Service Line Collaborative website. So there are web-based tools and resources that are there to support and accelerate any interest out there in lead service line replacement initiatives. Next slide. So on the website there's a roadmap, a replacement practices, a guidance amount of information, some policies, draft policies, resources, and information about who again makes up the collaborative to date. We encourage ongoing feedback. I mean, this is the first time. It was a process just getting the website together for sure and just trying to come to some agreement of how the information should be organized and in what way would be most meaningful. We welcome your feedback, positive and or negative, and any other resources that you know about that are not currently captured that would be relevant. Next slide, please. So the roadmap does pose questions to help local communities in figuring out what plan works best for you. We acknowledge that there is not a cookie-cutter approach to this at all. While there could be some model best practices in some way, it's rare, I'm sure, that you're going to find an exact program that's going to work in Cincinnati, Ohio, that's going to perfectly work in Detroit, Michigan, for example. But at least there are aspects of the roadmap by asking questions as the community is working through this process that hopefully will make it a bit easier. Also, the roadmap provides information that is critical to plan, development, and implementation, and even legal factors and funding strategies. So we are really trying to go to those places that are really at times some of the most challenging for the communities being served. Next slide, please. So when we look at replacement practices, there's technical information and tools that are needed to successfully carry out lead service line replacements, and I have certainly continued to build up my own understanding of this and be educated, and there's a lot of helpful partners at the table that know these topics very well, and these topics include approaches to replacement, preparing a lead service line inventory, understanding replacement techniques, communicating effectively about lead service line replacement, and coordinating and implementing replacement, all very critical stages, no doubt. Next slide, please. On the policy side, there's efforts to look at opportunities for a variety of national, state, and local government policies, as well as private sector players and support in these replacement initiatives, and looking at examples, some local and state examples where effective policy and actions are in place. The collaborative is not an advocacy organization. We want to make that loud and clear. Its members may advocate for federal and state policy on our own, but not doing so in a collaborative way or as representatives of this collaborative. Next slide, please. There are other resources that are available, introductory information, equity considerations. There's a portion on schools and child care facilities, especially where children spend a good amount of their time, research needs, and case studies. Next slide, please. So why should hopefully this be important to you? We do believe that this provides a significant opportunity to reduce the risk of exposures to lead in drinking water in the communities that you're serving and or living in. And there are many things that you can do. We do offer up resources in a categorical type of way. If you're a healthcare professional, public health professional, if you're a water professional, on and on. We hope that there, at least for now, there's the beginning of some types of information for you. And again, do encourage you to let us know of other content that would be relevant to you in the networks that you serve. But your help working with your community leaders, your elected officials, and drinking water professionals to consider lead service line replacement initiatives in a serious way is encouraged. We need help creating the public health case for a program and providing expertise in health messaging, effective health messaging, and consumer education. Messaging that's going to work for the targeted communities at hand, and working to ensure that initiatives benefit everyone in the community equitably, regardless of income, race, or ethnicity. And we welcome your feedback. Next slide, please. So we do want to acknowledge the W.K. Kellogg Foundation and the Pisces Foundation. There are a lot of different ways they could have been spending their support, but they really have felt the urgency in the last few years and wanted to be a part of solutions. So we very much acknowledge their support, and we are always looking for additional support, and we do want to acknowledge the in-kind contributions from all members of the collaborative as well. Next slide, please. And here are the current members of the collaborative, just for your information. Anyone that's listed with an asterisk represents members of our steering committee, which meets on a regular basis. And I believe that's the last slide for me. Yep. So at this time, we are going to go and start asking some of our questions. We've got about 15 minutes left. If you have any more questions that you'd like to get in the queue, please do just type them in there, and we'll try to do the best we can. I've got two here for David Bellinger first, from Catherine. What is the control rate of 4th grade failure for reading per your slide that you had referenced?
Well, I think the best answer is that the rate among children who had a blood lead level of 1 microgram per deciliter was around 10%. Obviously, there are a lot of reasons why a child might not do well in reading. And 10% seems to be about the background rate. And that's consistent with the percentage of children referred for special education services is usually somewhere between 10 and 20%. Mm-hmm. But some of those may be attributable to lead.
Thank you. And my friend Rebecca Morley is on, and she has two questions. One at least is for you, David, as well. In 2010, the World Health Organization determined that the lead levels of food of less than 0.3 micrograms per deciliter were inconsequential because they resulted in a decrease of 0.5 IQ points. But that intakes of greater than 1.9 micrograms per deciliter were of public health importance because levels at or above 1.9 would result in the loss of 3 IQ points. So how does one decide what is quote-unquote consequential IQ point loss?
Well, that's a tough question. It's really a value judgment. It's how much impairment or decrement is a society willing to accept, given whatever benefits are associated with the use of lead in a particular application. So I don't think there is one answer to that, and different individuals will have very different responses. And I think it also matters whether you're focusing on individual risk of individual children or on the societal level that I was trying to get at in my last couple of slides. That this is an example of what the Jeffrey Rose back about 20 years ago called the prevention paradox, that it's a lot of the health morbidity in the population is contributed by people who have values on risk indices that don't appear to place them at increased risk. And so that if we halved, let's see, if we reduced, say, the systolic blood pressure by 3 points in the population, the mean systolic blood pressure, we would cut in half the number of people who have a systolic blood pressure greater than 140 millimeters of mercury, the standard clinical definition for hypertension. So distributions of these health indicators move as a whole, and I think if we focus just on the high-risk tail, I'm not saying we shouldn't focus on the high-risk tail, we certainly should, but we should also be concerned about what's happening in the rest of the population at other points in the distribution.
Thank you. And then also from Rebecca, did CMS revise its regulations for the allowable lab error?
I don't know the answer to that.
Okay, thank you. And then Elizabeth had 2 questions. To any of the panel members, are you aware of any efforts to advance universal blood lead level screening of children? Any states that do a particularly good job or poor job? So I know Adam did mention Maryland as being one, but any other state examples from speakers?
I think Massachusetts has done a good job along with Maryland.
Mm-hmm.
New York screens prenatal blood lead levels in women. I think that's the only state that does that.
In Ohio, it was all risk-based, and then the same thing with Maryland. I mean, not Maryland, Pennsylvania. That's the hard part is every individual state makes their own rules and then advises their own questionnaires and has their own resources to deal with the issue. So it gets really, for a provider, complicated to make sure that they're doing what they're supposed to, particularly if they move as much as I have.
Thank you. Also, Elizabeth is asking, how expensive is it to do a blood lead test?
Most insurance companies cover it, and actually, interestingly, most Head Starts require it, so that's the preschool for children whose families' income levels are low. They want evidence of their lead levels, so I think that's one way that it inadvertently requires it. But the insurances usually cover it, Medicaid covers it. There's, as I mentioned briefly, there are 2 ways to do blood lead tests. One is a venous and one is a capillary test, which is a finger stick. The finger stick method, the equipment itself to do that is fairly inexpensive. I'm not sure what providers would bill for it, though. That's one of the advantages of working in a hospital. I don't have that much control over it. But most of the time it's covered by insurance.
Thank you. Just to circle back for a minute, since we did talk about universal blood lead, to confirm, Rebecca's asking, do the speakers support universal screening? Is that the direction we'd ideally want states to be going in?
Well, so since I still am unmuted, I would say the push from the AAP's most recent guidelines is really what we should probably be arguing for. Primary prevention. You know, we shouldn't have to test kids to figure out if they're getting exposed. We should just get rid of all the exposure sources. But since there's so many different risks out there for exposure, and we know that any exposure is not good, it might make sense to go back to the idea of universal screening, but I think it's all a matter of risk and benefit ratio. So the test is not that expensive, but what are we going to do about it? If we don't have the resources to do the home inspections and figure out what the sources of exposure are, we're not going to be able to address the issue. I think universal screening in Maryland, particularly for where I work, is important, but I don't know that it's necessarily always worth the expenses.
And it can be very hard to identify the sources of a child who's got a blood lead of 5 or 6. You may not be successful in finding one predominant source. So I agree with the thrust of the movement to clean up the legacy sources of lead in the environment from the past uses, in gasoline and paint and so on, rather than continuing to use children as an indicator for where the lead is. Let's screen the environments rather than children.
Thank you. And Deborah has a few questions. She wants to know if we can point her in to studies that contrast the effects of lead on children exposed since they were in the womb to the effects of lead on children who've been exposed in, say, toddler or 2 or 3 years of age and on.
Now, that's actually, it's a very important question, but it's a hard one to get a clear answer to, because you need to identify cohorts where there has been elevated exposure prenatally, but then suddenly none postnatally, and then the reverse. And it's hard to do a population-based study that would enable you to accumulate that kind of a sample, because you'd have to do screening, prenatal and postnatal screening on the whole population in order to be able to select people with particular exposure profiles of interest. So that hasn't been done. The closest is in prospective studies such as the Cincinnati study I mentioned. We did one here in Boston. Others were done in Mexico City and Australia and Kosovo that enrolled children either prenatally or at the time of birth, and then follow the children for periods up to 10 years, 12 years, in Cincinnati case up more than 20 years, and then measuring lead exposure, blood lead concentrations at all those different times, and then seeing what timing of exposure seemed to place children at greatest risk. And that's not quite as clean as the design that you'd really like to apply to that question. And the findings were a little hard to interpret. The most consistent was that it seemed to be the postnatal exposures that were most persistently associated with longer-term outcomes. There were some findings that if a child was high both prenatally and postnatally, the outcome was even worse, not surprisingly. But it was a little hard to get a clear answer to at what age is the exposure worst. Partly it's a matter of, and I should have said that when I was showing the slide about development of the central nervous system, a lot is happening over a long period of time, which means that the impact of exposure at different times in that process may have different effects. And this is really the basis of the concept of critical windows of vulnerability. So there may not be a single answer to at what age is exposure most hazardous for children, because the exposure will be hazardous for certain aspects of central nervous system development at different ages. So I think the answer is much more complex than a simple age of greatest vulnerability.
Thank you. Thank you very much. Catherine asked, and Adam, this is specifically for you, why is 1960 a cutoff date for investigating homes?
So that sort of gets at I think the question relates more towards our screening questions, that when studies have been done about the ages of homes that are most likely to have lead paint in them, they decided that 1960 was a good cutoff for the homes that would be most likely to have lead. There was still lead in paint up until the late 70s. so that question could be worded a little differently, which is why I think that the questionnaire approach is less than ideal. But the number of homes, or the percentage of homes that have lead poisoning is have lead paint is significantly higher the older the homes are. And that 1960 cutoff was the one that was decided as being the most worthwhile number to stick with based on the percentages of homes with lead paint in national surveys.
Thank you. And I believe this is our last question. So Tom, we'll start with you. Deborah also wants to know, will the priorities of the current administration, in your opinion, affect the flow or availability of funding to these important health initiatives?
Well, that's a little hard to predict at this stage. I do know that when the administrator or the nominee for EPA administrator testified, he said revising the lead and copper rule would be a priority. So I think that will likely be one. There's not been talk in any other areas. There's also talk about investing in infrastructure, but housing is not usually thought of as part of that infrastructure. It's not usually part of that discussion. So the drinking water would be the area that I think you'll see most of the attention.
Mm-hmm. Thank you. Is there anyone else that wanted to just add to that last question, just from your opinion? It's hard to tell, right? But
have to wait and see whether there is an administration.
Yeah, whole nother note. Well, we really want to thank all of you for your time and attention and great questions. Again, I'd love to thank all of our presenters for their very well-informed discussions today. And we encourage all of you to go check out the Lead Service Line Replacement Collaborative website. And we want to hear from you. Please provide your feedback. Share it with your networks. This, like we said, is going to be a long-haul process, but the point is to see some actual action. And it's exciting to already hear back just from within a day of the website going live. We've already started to hear from some cities and some positive aspects that they are taking and initiatives that we will continue to feed and post on the site for everyone to view. So with that, we'd like to thank all of you, and I think you're seeing through the post that there will be an opportunity to receive information on this webinar. I believe it has been recorded. And again, if there's any other way, there is an evaluation that you will be receiving. We encourage you to fill that out. And sorry, Lindsay, I'm probably taking your final comments.
Oh, no, I think you've got it covered completely. We'll be sending out a follow-up survey as well as indicate where the recording can be found once it's posted online.
Great. Thank you all so much.
Thank you.
Thank you.
Bye-bye.
Bye.